Well, good morning, everybody, and it's a pleasure to be here, partly because I like talking to people, but also because I'm learning a lot about ME, which I didn't know about before, having spent yesterday at the more research meeting. So I try to find antibodies in neurological diseases, and these antibodies are useful for the diagnosis of the patients and also because it means they can be treated with immunotherapies like rituximab, although sometimes much cheaper treatments. And I'm going to talk to you about a few of those antibodies and try to at least show you that some of the features that the patients present with have some sort of overlaps with ME, and that may sort of stimulate your curiosity. So these antibodies are antibodies to muscle or neuronal proteins, and they're found in diseases of muscle, nerves, or brain. Are there similarities with ME or CFS? That's the sort of question I've been asking, and I thought I'd just draw attention to some of the features that I've found. So the main disease I'm going to talk, well, the first disease I'm going to talk about is called Myasthenia Gravis. You may have heard of it. This is the droopy doll disease, or I think we call it, which is a situation where the patient becomes very weak and fatigues very easily. So that's something that's familiar to you. But in this case, the weakness is very clearly defined because it's due to a defect in the transmission of impulses between the nerve and the muscle. Now, this is a young girl back in the 1970s, before treatments were well instituted, and you can see that she's got a lot of weakness in her face. She can't keep her eyes open. She can't swallow properly because her swallowing mechanism is weak, so she's being tube fed. She can't keep her mouth open, so she's keeping her chin up like that. Her mouth's very floppy. She can't smile, and she probably can't talk intelligibly because of the muscles of her mouth and throat and tongue. And she's also, in fact, had a tracheostomy and been intermittently ventilated. So that was a very severe disease back in the 70s, before we understood better what was going on. Here is a nerve from the motor system, so coming from the spinal cord. When you want to move a muscle, the nerves release acetylcholine, which is a small chemical that binds to acetylcholine receptors on the surface of the muscle, and that interaction leads to various processes that result in contraction of the muscle fiber. And of course, it happens within a split second, so it's a remarkable system, as indeed is every transmission of impulses between nerves and muscles, as in this case. So that's what we knew about the normal nerve-muscle junction. And in myasthenia gravis, it became clear that the main problem was that there weren't enough of these acetylcholine receptors on the postsynaptic, on the muscle side. The nerve itself seemed to be functioning perfectly well. But finding that there weren't enough acetylcholine receptors was a major step forward in understanding what was going on in these patients. And it turned out that it was caused by a specific antibody. You've heard today about the rheumatoid factor antibodies. Now, this is an antibody to the acetylcholine receptor. So not an antibody to an antibody, but an antibody to a protein, which is very important in nerve-muscle transmission of impulses. So antibodies you've already heard about, but this is my way of describing them. They're protein molecules. They're mainly made by white blood cells in the lymph nodes and spleen. They're released into the circulation. They can therefore be measured in the serum, which is the soluble fraction of the blood. And at the tips, shown very crudely here, are two variable regions that can bind to other proteins, like the rheumatoid factor binds to antibodies, as you've just heard from Jonathan. Now, in your blood, as Jonathan also mentioned, you have millions of different antibodies. So they've all got different tips, different colors. And mostly those are made completely randomly, unless you're vaccinated when you make them specifically. But the idea is that they will be able to bind to bacteriums or viruses and help destroy those and get rid of them. But unfortunately, sometimes they bind to proteins on the surface of human cells, and when that happens, you can get an autoimmune disease where your antibodies are attacking your own cells. And you've heard already about some mechanisms by which antibodies can cause damage to the joints. I'm going to tell you about situations where the antibodies cause damage to the brain or to the peripheral nervous system. So myasthenia gravis, back in the 1970s, John Lindstrom and colleagues at the Salk Institute recognized that there were antibodies to the acetylcholine receptor protein, which I showed you at the muscle, on the muscle surface, and that those antibodies are very frequent in patients with myasthenia gravis and are not found in healthy controls. And that may look colorful, but it's actually data from our own patients. If an antibody is causing disease, then if you take the antibody out, the patient should get better. Now, nowadays you can treat them with rituximab, but back in those days you didn't have that. But this patient was plasma exchanged. So what happens here is you take the blood out from the patient through an ordinary, like if you're donating blood, but it's centrifuged, and you take out the serum, or plasma as it's called, which is the soluble fraction of the blood, and the red blood cells are given back to the patient with a substitute protein, so that their protein content is not too much reduced. When you do that, and this was a patient who'd been ill for 30 years with myasthenia gravis, you remove the antibodies, so the antibody levels go down during the plasma exchange process, and the patient's strength goes up. A few days later, small lag, not many days in this case. Over time, though, the antibodies will come back up again because the cells, the B cells, are still making the antibody, so they continue to make it, and the patient deteriorates. Nowadays, of course, we use drugs as well, like steroids or various immunotherapies, to make sure that the antibodies stay down as long as possible, if not forever, and the patient doesn't get worse again, hopefully, but continues to remain relatively strong. Another way of showing that antibodies are important is to take the antibodies and inject them into mice. So this mouse has been injected with antibodies from a myasthenia patient, and this mouse from antibodies from a perfectly healthy person. And you can see the difference. I'm not going to go into the physiology of the disease, but here you can see a very weak mouse that's probably having problems breathing and certainly isn't eating and will lose weight and die if you don't look after it. And here is a very healthy mouse that's running around the cage. So transferring disease from patient to mouse is perfectly possible in many of these situations, and is very good evidence that it's an antibody that's caused the disease. So we know a lot about antibody-mediated diseases now, very largely from the work in the nervous system. The antibodies bind to the extracellular. That means the part of the protein that is sticking out from the cell. It's not the protein that's inside the cell, because the antibodies are not going to reach inside the cell very easily. They have to attack from outside. The antibodies can be measured in the serum. Antibodies cause loss of the protein almost inevitably, and the patients can improve with treatments that reduce the number and levels of the antibodies. Myasthenia gravis is also an interesting disease in a lot of other respects. In fact, there are at least two main types of disease, and this is becoming increasingly evident from a lot of data. And it's funny, it comes out, in my thing, this is pink and blue, which is obviously a sensible way of describing two groups of patients, but here it seems to be blue and blue, which isn't so easy. Early onset myasthenia is usually in the from about 15 to 35. There are more females than males, and they have one of those HLA antigens that Jonathan talked about. In this case, it's a DR3 antigen in their genes. So I call it an antigen, but it's a genetic marker for the immune response. But then increasingly, even more than this now, there are patients in their later years who are more males than females, and they have a different HLA association. So myasthenia, which in terms of the mechanism of disease is the same throughout these patients, probably has at least two main causes in the genetics of the patient. The genetics for these two forms of disease are different, even though the patients have the same disease. When you see them in the clinic, they have the same antibodies or same population of antibodies. When you remove the antibodies, they get better. So it is the same disease, but it has two different causes in terms of when it appears and also the genetic basis that makes it more likely to appear. And I think that's something which, to my mind, hadn't been explored very carefully in ME. It's also underdiagnosed, definitely, in this later population. So anybody over the age of 60 who gets weak, you shouldn't think necessarily ME, you shouldn't necessarily think stroke or motor neuron disease, but do think about myasthenia because it's a very easily treatable disease. There's another protein in myasthenia that's important. It's called MuSK, and it also sits on the membrane. It's also got a nice bit that sticks out from the membrane, and we showed that there were antibodies to MuSK in some patients, and that's a slightly different disease. So that's another form of myasthenia, not associated with acetylcholine receptor antibodies, but with MuSK antibodies. And here is a young woman who's had this disease actually for about 18 years at this point. She got it when she was only 2. She was perfectly normal before that. Now you can see she's been asked to smile. She really can't. Her eyelids are droopy, her mouth's all floppy. This was at the time that mobile phones first started being used by young people. She couldn't use her mobile phone because nobody could understand her speech over the telephone because it was so affected by the weakness in her mouth muscles and in her tongue, which you can see is very wasted. So she had a really severe form of myasthenia that was really difficult to treat. She'd had lots of treatments, but they never really made her better. She always needed more treatments. She can't move her palate at all, by the way. Well, barely. When asked to go, it just twitches a little bit. In fact, much more recently than that even, she was given rituximab, and she has done better. And she says she's better, and she says she can speak on a mobile phone now. So that's very nice for her. MuSK patients with these MuSK antibodies are also intriguing because there seems to be a geographical distribution of the disease. So if you live in Norway, in Bergen, where some of the speakers are today, actually it's very, very rare to see this form of disease. If you are in Rome, Cyprus, Istanbul, Barcelona, you see this disease quite frequently. And that suggests that there are geographical relationships which are probably environmental, not genetic, because of some data we have. And I wonder about that. Is ME seen everywhere? Or are there certain areas or certain countries or certain genetic predispositions to that disease? So I'm going to move now to something which gets nearer to the central nervous system. I'm going to talk about antibodies to what we call VGKC complex proteins. Now, VGKC stands for voltage-gated potassium channel, and you might wonder why that's potassium, but it's called kalium in some languages, and for some reason we've always maintained the kalium, the K for kalium. These antibodies are associated with both peripheral nerve and central nervous system diseases, and some features are similar to ME, CFS. And it started, for me, with this disease. So this is what we call acquired neuromyotonia. It's an autoimmune voltage-gated potassium channel disease. This patient had antibodies to this VGKC complex, and you see that he can't control his muscle activity. It's spontaneous. He's getting a lot of muscle cramps, and it goes on day and night. That's an interesting feature. If a disease is centrally generated, then when you go to sleep, that shuts off. But if it's generated in the periphery, in the actual nerves themselves rather than in the brain, then it won't stop when you go to sleep. So that's an interesting question for ME patients. So spontaneous muscle activity, twitching, cramps, weakness, sweating, and these patients also get pain, which was largely assumed to be cramps from the muscle activity. But it improves after plasma exchange to remove the antibodies or other treatments. We hypothesized that there might be an antibody to these potassium channel complexes, which are on the motor nerve, and they control the release of acetylcholine. So if you don't have potassium channels, if the antibodies got rid of potassium channels, then you will get more acetylcholine release and you get more activation of the muscle. And that's what we see in the patients. So it made some sense, and we looked for these antibodies, and we in fact found them. So what about the patients? Well, they get this twitching, weakness, and stiffness, but they also get paresthesia, that's pins and needles and things, and pain, which is not necessarily in the muscles. Some of it's in the skin, the joints, and it can be quite horrible. They also get a lot of autonomic disturbance, and autonomic symptoms seem to be very important in ME, and they get anxiety, insomnia, other sleep disturbance, and sometimes depression. And in fact, 2 of the patients of the 60 that are described here were so depressed that they tried to commit suicide, and one of them succeeded. I've had data from a patient survey from Australia on the nature of the pain, and it's described as aching, cramping, shooting, burning, and quite a few other adjectives as well. So this is real pain. It's not just discomfort in the muscles. And very recently, I got an email from Deborah Carter in the UK, who had, at my request, asked the patients what other symptoms they had. And it turned out, in fact, that there's quite a lot of symptoms that may be of relevance to you: fatigue, exercise intolerance, obviously, sleep disturbance, myoclonic jerks, internal buzzing and electrical zings. I don't know if that's familiar to some of you, slurred speech, etc. So there's a range of different features that these patients can suffer from. Now, the one problem with this is that it's very difficult to diagnose this disease unless you have very good physiological measurements on the patients or a very positive antibody test. And most of these patients may not have been correctly diagnosed. However, it does show that there may be some overlaps. Some of these patients have a much more central nervous system disorder with very severe insomnia, confusion, hallucinations, and disturbed circadian rhythms, so that they don't sleep at the right times, or they sleep during the day instead of the night, or hardly at all. These patients have very high antibodies, and the symptoms and signs improve with the usual treatments, even though this is a brain disease, and until fairly recently, people were saying that antibodies couldn't get into the brain, so how could you have a brain disease caused by antibodies? Now nobody asks that question any longer. This was first described by a Frenchman, but what I want to just show you is that there's a lot of electrical activity going on in the patient at rest, which shouldn't be there, and when we plasma exchange the patients, they get better, and you can see there's much less of this incorrect electrical activity going on in their nervous systems after plasma exchange. And this just shows you that some of the circadian rhythm, for instance, for melatonin, which we all know makes you sleepy, that's what it's meant to do. It's meant to go up in the evening, and in these patients, it's completely flat. Oops. So there are other diseases associated with these antibodies, and this patient, I won't go into the details, but he has lost his memory. In other respects, he looks perfectly normal. He's very rational. He speaks very coherently, except he actually can't answer the question being, do you remember meeting me before? And the correct answer being, no, we haven't met before. But he doesn't remember, and he knows he can't remember what happened even that morning, and so he confabulates. He builds a whole story and explanations, and he creates words and sentences that are coherent, but they don't make sense in the context of the question, and the reason is he can't remember anything that has happened up to about 5 minutes ago. So this really dense amnesia is also associated with the same antibodies, which is a little bit curious. I'll tell you about that in a second. They have really severe memory loss. They have seizures very often, epilepsy, personality change, and sometimes psychiatric disturbance. They often have brain MRI changes, but they don't necessarily. They often have a low plasma sodium, which can be noticed if their blood is tested, but not necessarily. But what defines them is these very high antibodies and the fact that they respond very well to treatments. And here is a patient who, by the time he was diagnosed, 5 months into his illness, he was essentially comatose with a lot of seizure activity, very severely ill indeed. But once diagnosed, he was treated with steroids, plasma exchange, and intravenous immunoglobulins. The antibodies came right down, and about 3 months later, here he is sitting up, talking coherently, although he can't remember anything that has preceded or anything during this whole period. So he has a very dense amnesia for that period, and he continues to have problems with his memory, but can cope and goes home and lives independently. What we then found was that the antibodies were actually not against the potassium channel, which is this protein here, but actually against other proteins that are part of this whole complex, which is how the potassium channels function in the brain and in the peripheral nerves. So it's a more complicated story. That's not in itself important for you, except to say that we now measure the antibodies by a different method. And in this case, it's difficult. This is very difficult because we've lost some of the red color. Excuse me. Anyway, I don't know when these colors change, but computers do funny things when they're projected. Anyway, this is meant to be a green protein called Caspar-2 on the surface of a cell, and we've made that cell express this Caspar-2, and we're asking, does the patient have antibodies to the Caspar-2 molecule? The patient's antibody is in light blue on your screen, and what used to be a red color is now black. So this is the second antibody, the antibody to an antibody, which in this case we're using as a way of marking the fact that the patient has antibodies to this protein. And what you should be able to see in the picture below is red around the green cells, or the yellow cells in this case. Unfortunately, you can't see the red, but if you did see it, you'd know that that patient had got antibodies to this protein, and this we look at under the microscope. If the patient doesn't have the antibodies, you don't get the blue antibodies binding or the black ones, and you don't see anything around the cells. And we do that test now for hundreds of patients, well, thousands of patients every year, and we do a lot of other tests in exactly the same sort of way because we believe this is very important, because we're looking at antibodies that can bind to the outside of a protein as it exists in the cell membrane. Antibodies to LGI1 are one of the important antibodies. Those are the ones that are most associated with the memory loss and seizures. And we know these antibodies are important in patients because if you take neurons in culture, so this is a nerve cell from the brain in culture, and the green that you can see is the patient's antibodies binding to little synapses, so communications between the nerves on the surface of this big nerve here. And that's a brain cell, the kind of brain cell which is important in memory, that goes wrong when you have epilepsy, etc. Sometimes these patients have little myoclonic jerks, so that was one. And in order not to take too long, I'm just going to go forward. But that was never recognized as a seizure, as an epilepsy form, until very recently. And the reason it was recognized was because we showed that this patient has these antibodies. So without the antibodies, nobody would have noted that. There are, in fact, 2 more antibody-mediated diseases, which I'll just show you very quickly, because sometimes these antibodies are associated with tumors. And in this case, this particular antibody can be, but is not necessarily associated with what's called a teratoma of the ovary. So this is a tumor which expresses a lot of different types of protein. And one of those proteins is this protein, the NMDA receptor. And here is the young woman who has this antibody. She presents with psychosis, really, loss of memory and epilepsy, and then she develops this syndrome over time. So she has terrible movements like this that go on for weeks. She's actually essentially unconscious at this stage, and this is obviously a very severe situation. Young girl, perfectly healthy previously, with funny movements in her face, funny movements in the arms and legs, and until recently, no obvious treatment to use. But now we know this patient and many others have got antibodies to this NMDA receptor, and when you treat them, you take out the tumor if they've got one. She didn't have one, and they make a very good recovery with other immunotherapies. We know those antibodies are against glutamate receptors. The NMDA receptor is a glutamate receptor. It's a very important receptor in the brain for the communication between nerves and nerves. And here's a little child with the same antibody. Terrible disease, but when you identify the patient, you can treat them much more convincingly and effectively and with great confidence. And here she is on the way to recovery. She's now back at school, although unfortunately I think there was probably too much damage at the time, and she probably won't be 100%. But this is interesting. The reason I wanted to show you that disease is because sometimes this is post-infectious. This can be apparently driven by an infection. So this child, this is a different child, it's about the same age though, was a young child who had an HSV, a herpes simplex viral infection of the brain. She had a lot of brain damage shown by all this white around the brain. And that was very unfortunate, but she got better with the antiviral treatments that are used in herpes very effectively. She went home, and then she got worse again. And when she got worse, she had all these funny movements. And that rang a bell, because now we know about that NMDA receptor antibody. So she was tested. She was positive. She even had it in her brain fluid, the cerebrospinal fluid. And here was the disease during which she was getting all these movements and difficulties. But she was treated with plasma exchange, and she's got better. Her antibodies came down. This is now one of probably at least 20 cases that have been reported now of children with this disease, which seems to be driven by the viral attack on the brain. So in this case, not a virus just giving you a bit of flu, but in this case, giving you brain damage, which then initiates this particular antibody. And like Jonathan, I think that many people can make this antibody, but you need something to drive it. And in this case, it was the infection. And then just finally, there are other diseases caused by antibodies. This one's an antibody to the glycine receptor, but I'll go forward because I don't think it's particularly necessary for your talk. So there are a growing number of antibodies to channels and receptors and to ion channel associated proteins in neurological diseases, and this has been a really new field. There are lots of different features in these patients, some of which may be analogous to the sort of problems that ME patients suffer from. Patients include children. There are less severe and isolated or atypical presentations that need to be recognized even in these diseases, and possibly that applies to you as well. And there are now a number of antibodies which are identified in these patients, but in fact there are far more than I've mentioned today. I think the antibodies are best detected by these cell-based assays that I've mentioned. The patients respond to plasma exchange and IVIG, and in the past we have used that as a way of showing that the patient had an antibody-mediated disease. So John Newson Davis back in the 80s, if he wasn't sure, he'd plasma exchange the patient and see if they got better. So that is a sort of diagnostic test. They can be post-infectious in some instances, and the antigens are discovered either because they're candidates for the disease or by methods which I'm not going to discuss here, but could do if anybody's interested. There are a lot of other conditions that are also raising questions about new antibodies, and these are just 3 of the areas that myself and colleagues are interested around the world. Narcolepsy, which can be post-H1N1 vaccination, Tourette's, PANDAS, and autism. So I just leave you with my colleagues who've done so much of this work. Thank you.
Thank you very much. Angela, could you take a couple of questions, please?
Of course.
Okay, thanks. Yes, sir. Gentleman in the back there. Yes, sir.
Yeah, I was wondering, do you find with voltage-gated calcium channels, are they found outside the central nervous system, in muscle cells at all, or is it solely, you know,
the potassium channels, not calcium, you are talking about potassium channels or calcium?
I was talking about voltage-gated calcium channels. But
calcium channels?
Yeah, calcium channels as well.
I didn't mention calcium.
No, I know, but okay. I'm just interested.
Yeah, no, they're both in both. They're throughout the nervous system.
Okay.
And there are some in muscles, but there are lots of subtypes of these.
But in theory, you could form an antibody to the VGKC in muscle cells as well. It's
called a different type. It's a different type of calcium channel in the muscle. There is yes, there is. It is possible, and in fact, there may even be some in myasthenia. There's some data about possible ones in myasthenia, which may or may not contribute to the disease.
Just one thing, I was wondering if you ever notice any difference in the efficacy between plasmapheresis in these autoimmune diseases and like rituximab, you know, which targets just certain B-cell subtypes.
It's interesting, but in fact, in the diseases that I've talked about, on the whole, we prefer plasma exchange and at least getting rid of the antibody and then coming in with high-dose steroids and maybe intravenous immunoglobulins, which help keep the antibodies down because you're replacing normal healthy IgG antibodies. And we don't use a lot of rituximab. Some people do use it, but they tend to use it also with cyclophosphamide, which is quite a drastic treatment. So everybody has slightly different ideas. There's very few guidelines on how to treat any of these diseases. And I think there's a lot of doctors feel that they need to treat each patient as an individual anyway, because you can't always predict how well a patient will do with any of these treatments. You have to try, watch, monitor, and be prepared to try something else.
Thank you.
Thank you. One last question, sir.
Henrik Nielsen, Copenhagen. Thank you for an excellent presentation. I'm wondering, I have 2 questions. One is, are we too much focused on one T or B cell mechanism? And do we need to introduce again the plasma exchange as we used 30 years ago before the biologicals were introduced? Are we too little aware of other mechanisms than B and T cells involving in the ME symptoms? Have you any
well, I don't work on
awareness
ME.
of this has been used in ME?
I think plasma exchange is beginning to be used in ME. I wouldn't be the person to comment on that because I know very little about it.
Maybe other ones could do that. The second question is the HEP2 cells we have used for immunology for years as a cell assay, as you mentioned, for the neurons assay. And I wonder, the CASPR2 assay, has that been used in ME?
The CASPR2 assay and all the ones that we've done, there is somebody he can tell you about it if you want, but I gather that they've used a commercial assay for several of these antibodies and haven't yet found anything. My only provision about that, proviso, is that they use a slightly different form to how we do it, and our form, we believe, is probably more sensitive and more appropriate, but so far nothing positive has come out.
Okay, thank you very, very much, Angela, indeed. Thank you.